Good evening, everybody. My name is Mike Gallagher, and on behalf of the Michigan ACC Virtual Education Work Group, I'd like to welcome you to our second ever virtual webinar held as part of the Second Wednesday at 6 series. This Second Wednesday at 6 series was an idea that our president, David Wones, and Alice Betts created about 6 months ago, and we've had a great group of task force members that have come up with really an agenda of 12 monthly meetings, either grand rounds, format sessions, or case-based webinars. This series was promoted to or developed to promote collaboration between centers throughout the state of Michigan, and it's a new platform for virtual education throughout the state of Michigan to really encourage as many hospitals and fellowship training programs to unite in this virtual education format. We really encourage you to share this webinar with your colleagues and promote this throughout your institution, and in particular your fellowship programs. For those of you on the webinar last month, we discussed the format of these webinars. Each webinar is a collaboration between a host site and a moderator site to further encourage and enhance discussion and educational content. The format for this evening's presentation will be a case-based discussion on the topic of the management of multivascular or multivessel coronary artery disease. Several presenters from the host institution, the Detroit Medical Center, will present a case as well as educational content. And between each lecture, there will be time for a moderated discussion, and there will also be time for a moderated discussion at the conclusion of the lectures. Michigan Medicine is our moderator site tonight, and the Detroit Medical Center will be our host site. A few housekeeping issues. We encourage you to submit questions through the QA box feature on the Zoom chat room. We'll have digital moderators who are fielding your questions, and they'll do their best to incorporate your questions into the moderated session. We'd like to, if you could switch the slide there, we'd like to thank our sponsor this evening, Zoll LifeVest, generously supported this evening's educational webinar, and we're very grateful for their support. I would now like to introduce Dr. Chadi Alrays, who is one of the lead members of the education task force and a faculty member of the Detroit Medical Center. He'll be presenting a case this evening and kicking off this webinar on the management of multivessel coronary artery disease. Dr. Alrays will then introduce the remainder of the faculty from the Detroit Medical Center and from Michigan Medicine. So Chadi, take it away. You're on mute, Chadi.
Yeah, that's the first mistake number one. So thank you again, Dr. Gallagher, for the introduction, and thank you all for being here. A few housekeeping items before we start is please use a Q&A box to post any questions. We want this session to be interactive and educational for you, especially if you have similar cases or close to similar cases that you would like the panel to discuss with you, the management for these patients. With that, my name is Shad Reyes. I am Director of Interventional Cardiology Research at Detroit Medical Center. And my co-partners here and from DMC is Dr. Kaushik Mandel. He is Professor of Surgery at Wayne State. He's a cardiovascular surgeon at Harper Hospital at St. Grace. And Dr. Aziz Al-Khatib, he is also an interventional cardiologist. He's a clinical associate professor at Wayne State University, and he is Harper University Hospital CCU director. This is our DMC group. We're going to be presenting to you the management of multivessel coronary artery disease. Our moderator, we're privileged to have Dr. Nadia Sutton, who is Assistant Professor of Medicine at the University of Michigan or Michigan Medicine, as well as Brett Wanamaker. He is also an interventional cardiologist, clinical assistant professor of medicine at the University of Michigan, and Dr. Fakuhara. He is a cardiovascular surgeon and assistant professor of medicine at University of Michigan. Again, as a reminder to the audience, please use a Q&A box for questions, and we'll be happy to entertain these throughout the webinar. And also we have a 10 minutes block at the end for discussion. Starting with my presentation, the title that was assigned to me, Decision Making for Management of Multi-Vessel Coronary Artery Disease. As we know, this is a common problem encountered recently, especially with the impact of comorbidities, and especially in Southeast Michigan. And the patient we see here, especially with the zip code that we're covering here, we have the highest dialysis concentration in the country. So that make us kind of the cornerstone for multiple management protocol for these patients. With that, I will start with the case that is going to be the discussion of tonight. It's a 59-year-old man presented with chest pain. He has a past medical history of hypertension and smoking. Nothing beside that. He just take lisinopril 20. And when he presented to ER, he was kind of complaining of dyspnea. And part of the workup, all his labs came back okay, except his sugar was in the 250, 260. And troponin came back at 21,000, high sensitivity troponin. His EKG was suggesting ST changes in the inferior lead and T-wave inversion. These findings kind of triggered the emergency department to call cardiology on call and to evaluate the patient at the bedside. Again, the patient is not too much symptoms and kind of stable. And he reported that he's been having these symptoms for almost 2 weeks on and off, but he continued to go to work and continued to smoke and do his daily stuff. Starting with the first shot, doing the LV-gram, as you see there, the LV is ejection fraction is reduced, especially consistent with the inferior leads. The inferior wall is hypokinetic with some global hypokinesia, but the anterior and apical wall coming in better compared to the other walls. And part of the arrow in the middle, it's a part of our MAC report. I couldn't get rid of it. This is his angiogram. Again, starting from the left side, this is a spider view, which is at LOO caudal and the 25-25 angle for the fellows on the call as well. As you see, there's a left main does not have much of a disease, but it gives rise to a circumflex that has disease proximally as well as LAD. On the right panel, you see this is an LAO crani, again, to delineate the LAD very well and showing severe disease involving the proximal segment, as well as circ disease involving the proximal area. As off note as well, it's the left to right collaterals, which suggest that the acuity of the symptoms and the findings of the angiogram consistent with the symptoms of the patient who's been having pain and symptoms of dyspnea for 2 weeks, to the level that maybe he started to develop some collaterals. So far, we don't have the culprit, but we'll be seeing more images. This is more an AP cranial on the right side, showing opening the proximal LAD disease, but more severe disease, almost 90% disease occlusion in the mid LAD at the takeoff, bifurcation lesion to a good size diagonal. Again, showing there the collaterals that's going from left to right on the right and left panel. This is the RCA. I mean, no surprise, this is kind of consistent with the EKG findings. Again, you see there, this arrow, again, the white arrow pointing out the clot is a filling defect, and obviously it's very demarcated clot approximately with 100% inclusion, TIMI-0 flow of the RCA. Giving this presentation, we actually went after the wire after this lesion. But I would like to stop here, ask the panel, what will be your approach from the interventionalist as well as the surgeon from your perspective after seeing an EKG, the left side and the right side?
Chaddy, it sounds like the patient had kind of a subacute presentation, but it looks like there's thrombus in that proximal RCA and he has ongoing symptoms. So to me, I would want to go after what I thought would be the culprit lesion and then try to consider what type of approach, maybe a surgical versus PCI approach, the LAD bifurcation. Curious to hear from my colleagues at Michigan Medicine.
Yeah, I totally agree. I think you have angiographic evidence that the right was the culprit lesion here, but this is it's a complicated situation because you're also thinking not only what you're going to do right now, but your next 2, 3, and 4 steps down the road for this patient, and the implications of what you're doing now affecting revascularization down the road. So I think that, given evidence of ongoing ischemia, the wall motion abnormality that you see in this angiogram, we're going to go after this as the culprit lesion and go for likely PCI of the right.
So I'm going to ask differentialists on the call, what would be your approach, what wire, and what will be your pharmacology?
So, I mean, typically I use a Pro Water Flex as my workhorse wire, but I mean, certainly there's others out there, the Run Through and Sheehan Blue, sometimes people use. I would, given the thrombus burden here, probably have a pretty low threshold for using a medication like either tirofiban, which we don't typically use very much at the University of Michigan, or eptifibatide along with heparin, but certainly there are different approaches. I think it also depends on if you think the patient's going to be having surgery. But I mean, ultimately, if you're planning on stenting, you're going to need some kind of a antiplatelet on board. So,
all right. So that's indeed what we have done. We started with wiring the lesion. It took us some time to go through the lesion, which speaks to the chronicity of the symptoms and the more established organized clot in the RCA territory. But eventually we were able to go with the run through. We exchanged from power turn to run through to get through the clot. And as you see there, because of the we started ballooning, but we didn't get much of a lumen. And because of the organized clot, we performed thrombectomy using a thrombectomy device called CAT-RX penumbra, which is continuous negative pressure aspiration. And to your point, also, Nadia, we did as well give 2B3 inhibitor tirofiban bolus to kind of loosen up more of the clot as it was more organized, and no surprise because of his symptoms that has been chronic. And again, off note, when I asked the patient why he didn't show up to the hospital on time, and again, which is, I think, majority of us, maybe we'll touch on it later on, is he was afraid to come to get COVID in the ER, which is becoming a major problem for acute illnesses such as AMI, ACS, as well as stroke. So this is after kind of finishing the balloon angioplasty, doing aspiration thrombectomy. We have TIMI-3 flow, good result. And as you see there, this dominant RCA giving large PDA and multiple PLBs, disease kind of extending from the proximal all the way to the mid to distal segment, which is require more work. But now I would like to pause here again and ask, what would be your approach for this patient who we already saw that we have LAD disease, bifurcating to a large diag, as well as proximal circ, and now you have an acute RCA lesion.
what do you think, Brett?
Yeah, I think my typical approach in these situations, some people talk about leaving it with a balloon or aspiration only result, especially if you think it was, perhaps embolic phenomena. But I think you have strong evidence for current or recent plaque rupture there. And so typically my habit is to go ahead and stent these lesions. And then as far as the remainder of the disease goes, we can have a conversation later once the patient's stabilized. And obviously you're going to check their hemodynamics and treat the shock if that's present. But typically to go ahead with PCI here and then sort the rest out later.
Yeah, I totally agree. I think that would be my approach as well. Shinichi, any thoughts from you? Have you ever sort of been in the practice of, like, if somebody calls you after an acute lesion and they have other surgical disease, have you been in situations like that where you've taken the patient, to the OR and not stented and potentially treated all three vessels with bypass?
Yes, I have been in such situation many times, and I think it highly depends on, the cardiology colleagues who are treating these people, and then some cardiology colleagues have much lower threshold of calling us, and then I also have a very low threshold of taking these patients to the OR if I feel that's very appropriate. The factors, including maybe age, and then whether the lesions are complex or not, and then these factors also play, but yes, I have been in such situation many times. Yeah.
Would be there a barrier for you, Dr. Fakuhara, if somebody, let's say, ER loaded him with Plavix or Ticagrelor, would have different consideration having the patient receive this medication?
Yeah. So as a same as all other surgeons, I try to wait if they receive anticoagulation, immediately prior to getting called. And then, but if patient is having persistent chest pain, and if this cannot wait, then I don't hesitate taking these patients to the OR despite the anticoagulation.
Thank you. All right, just for the sake of time, I mean, as you know, we always use syntax score to evaluate the complexity of the coronary disease. In this case was 15, and this is an easy tool. You can do it online, and it's available readily on Google. In this case, his risk of cumulative risk of events, which is MACE mainly, was 32 for the stent, and CABG is 28.6. And to give more insight, syntax score 2 has been added, which is include other comorbidities, have into account the patient age, kidney failure, and other comorbidities, which is generate eventually a suggestion and recommendation. However, this was developed for patients who have stable ischemic heart disease, as well as those who has not as acute thrombotic lesion like this. Although the recommendation was CABG, this is what the guideline, the recommendation by the syntax calculator. So it's, again, as I mentioned, it's available readily, generated and developed by the syntax score that they presented their 10 years follow-up data in 2019 at the ESC meeting. To give you an insight, this is a European multi-center as well as US and international randomized trial, 900 plus in each arm, randomized over the course of a year, over 10 years. As you see, the cohort is very comparable in terms of syntax score, diabetes, and the burden of disease, left main or three vessel. The primary endpoint for all comers, left main and three vessel disease, was in favor of CABG. However, it was not statistically significant, because when they break it down to three vessel compared to left main, three vessel disease did win with 24 CABG and 27 for PCI, with a significance statistically. However, when you look at the left main, things are kind of close to what Excel showed in terms of outcome at 10 years. And having in mind, this is a 10-year-old generation of stents, not compared to the second and third generation stents that we have now. But again, this is a very more robust data. This is the most graph that I use in my practice when I see these patients coming with three vessel disease, and this is where I plug the patient, whether they are here in the left with overall cohort, but mainly if they have three vessel disease, and what is their syntax score. Again, back to our patient, he has a score of 15, so he will be falling in here in three vessel disease, and 15 will be very low syntax score. So as you see, it's favoring CABG, but the line does cross the midline as well, which can be PCI as well. For our case, as Brett mentioned on the call, as well as Nadia, we ended up doing PCI to the RCA and was referred for CABG, staged down the line for LAD and diagonal. With that, I would like to stop my slides and see if I have any questions from the audience while Dr. Kaushik Mandel prepare his slides. I think there's one question from Mahmoud Asad. Brett,
yes, so the question is, or actually just a perspective. So there's good TIMI3 flow post-balloon, would definitely consider coming off the table and taking the patient to the OR. It was stable and not a STEMI. I think it's definitely an option depending on kind of what the local practice is. Sometimes these patients, and it sounds like Chadi, this one was too, are kind of in a clinical gray zone. It's not quite clear, how acute the lesion was, although it probably was the culprit lesion. They're late presenters or have questionable ongoing ischemia. I think restoration of flow gives you options, and There's some flexibility now with an IV P2Y12 inhibitor infusion, and you can sort of have that conversation and buy some more time. So it's definitely a valid option.
Yeah, I was just going to add too. I mean, in light of the complete revasc study, because there's so much sort of discussion around the ischemia trial. Well, I would say that this patient does not fit into the category of patient that would have been included in the ischemia trial. So we definitely don't want to leave the other disease in this particular patient. This patient would have been included in, complete revasc and would have been actually better served by having complete revascularization of the remaining vessels. So that's another thing, is that I wouldn't manage the rest of the disease medically.
Thank you. Dr. Mendel, do you want to take it over from here?
Yep. Thank you for the opportunity to be part of this webinar. I'm a cardiovascular surgeon, and I'll be giving a surgeon's perspective. The opening slide is from that of a robotic mitral repair that I do, but the reality still remains starkly staring on my face that 70% of my practice still is coronary artery bypass graft surgery. No financial disclosures. I am conflicted. I'm a surgeon, so the talk will be biased, trying to give more evidence in favor of CABG over PCI. Please feel free to counter me. Starting with the landmark paper by Salim Yusuf in Lancet 1994, that took all the randomized control trials prior to that date, comparing CABG to optimal medical therapy as it existed back in 1994. And then they came up showing that the CABG patients experienced a 39% mortality reduction over 5 years, despite a 37% incidence of crossover of CABG from the OMT group. They identified the classic indications that we all operate and base our referral patterns today: left main stem stenosis, 3-vessel coronary artery disease, and patients with ischemic cardiomyopathy. One thing of note, that preoperative severity of angina, an important consideration in the ischemia trial that I'll briefly allude to, was not found to be of any prognostic importance in this well-validated meta-analysis. The meta-analysis of Yusuf et al. Exclusively was comprised of patients with stable ischemic heart disease, presenting some recent evidence from a JACC paper by the Freedom Trialists group, wherein they looked at patients with diabetes presenting with acute coronary syndrome, somewhat comparable to the patient that we just discussed. And again, whether you take MACE, whether you take other complications, CABG tended to outperform PCI even with those presenting with acute coronary syndrome. 8-year outcome for the Freedom Trialists. The above red line is for the PCI group. The lower line is for the CABG group. And you can see almost a 28% reduction in all-cause mortality if patients with multivessel disease underwent coronary artery bypass graft surgery, especially if they have diabetes. Barry 2D also came up asking the same question, and the data turned out to be in favor of CABG, and PCI did not outperform OMT. Patients with reduced cardiovascular ejection fraction, comparing CABG to PCI. This is a paper from Mark Ruel's group, which came out in JAMA Cardiology just a few months ago. A large retrospective cohort study performed on the Ontario database, looking at those with EF less than 35% with LAD, left main or multivessel disease. They excluded other patients with other concomitant procedure, those with dialysis and cancers. And again, a significantly higher rates of mortality and MACE were noted in the patients who underwent PCI compared to those who underwent CABG. Courage, as it compared, although granted with a bare metal stent, in its armamentarium, again failed to show any benefit of PCI over optimal medical therapy. Ischemia trial, worthy of mention. However, one main point of clarification, ischemia did not compare revascularization strategies. Ischemia compared whether it would be appropriate to wait to perform coronary angiography in patients with moderate to severe ischemia versus proceeding with coronary angiography right away. So it was an early invasive intervention strategy versus a conservative strategy. There was a pretty significant crossover, 21% patients who were supposed to be in the invasive strategy group did not get revascularized. About 20% patients who were in the conservative strategy group ended up getting revascularization. 59% of the patients underwent PCI. CABG was grossly underrepresented in the ischemia trialists. So again, trying to decipher through this data to say one is better than the other, especially when the trial was not powered to do so, would be highly fallacious. Coming to Syntax trial, an important reminder that the Syntax score that we all talk about was not an a priori hypothesis for the Syntax trialists. They did not intend to set out to stratify disease. It's a post hoc subgroup analysis, and it's exposed to the usual statistical fallacies when you're doing a post hoc subgroup analysis. Another reminder at how the trials at times tend to bias. If you really want to have a good head-to-head comparison between two strategies, keep everything else same. Look at the medications that the PCI patients were getting versus the CABG patients were getting. Only 20% of the CABG patients were on antiplatelet at discharge. Similarly, a very low percentage of patients getting statins. And those factors are not discussed aloud when the conclusions get written or discussions are being put forward in editorials. Continuing with the Syntax story, the Freedom trial that looked at multivessel disease in patients with diabetes, irrespective of what the Syntax score is, CABG outperforms PCI in terms of subsequent mortality or MACE rates. This particular paper looked at importance of LDL targeted control. Look at the bottom line. In patients with 1-year LDL-C greater than 70, as in poor cholesterol control, patients with CABG has significantly lower MACE rates. And a similar consideration, if you have a non-compliant patient, probably CABG will offer advantage over PCI. And it's a consideration that a lot of our cardiology colleagues do strongly think about and discuss aloud. Any CABG versus PCI trial, one thing that stands out consistently across the board is PCI group will have a higher revascularization rate. Talking of Excel follow-up paper, 3 to 5 year data, patients undergoing left main PCI had a significantly higher need for revascularization. And this was not free of cost. There was a mortality cost attached to these revascularizations. So again, something to be thought about as we are planning to decide what's in the best interest of our patient on the table. And finally, PCI, when it does the target lesion treatment, and if you look at this particular graph, for the first year after an acute coronary syndrome, the hazard rates are primarily related to the target lesion. But beyond the first year, it's all the non-target culprit lesions that become important to give rise to the subsequent events. And CABG consistently, especially with arterial grafts, its nitric oxide production and protection, field protection effect that comes in, protects against the development of these future culprit lesions. So it would not be fallacious to say that CABG is superior to PCI for multivessel disease and those with left main stem stenoses. We can discuss Excel and Noble separately, but and especially if the patients have diabetes and they have an impaired EF. But this is only possible when we as surgeons keep our mortality and morbidity rates low. Our group at DMC uses the following 6 things in our bundle to enhance recovery for our CABG patients getting revascularized for multivessel CAD. We check our work with the transit time flow measurements to look at the grafts. We use this for deciding the site of our cannulation and our clamp sites to reduce risk of stroke. Remember, that's an Achilles heel for CABG. In the Syntex trial, CABG patients had 2.2% risk of stroke compared to 0.6% risk of stroke for PCIs. With this strategy, there was recently a paper that was published in the JDCVS, wherein the stroke rates were in the order of 0.7%, very comparable to what's reported in Syntax trial. I'm an on-pump surgeon. To try and keep my stroke rates low, apart from using epi-aortic ultrasounds, I also use a single clamp technique. And in this paper, as you can see, multi-clamp technique, on-pump, off-pump surgery with side-biting clamp had a significantly higher incidence of neuropsychological deficits compared to single clamp on-pump surgery. Dual antiplatelets, especially in patients receiving vein bypass grafts, and especially in those getting their surgery done off pump, receive substantial benefit over just aspirin alone. This paper from the Sweetheart Registry again reiterates the importance of optimal medical therapy, guideline-directed medical therapy, even in CABG patients. And we as surgeons should literally demand it from our general cardiology colleagues once they get discharged from our clinics, that the patients need to be on statins for the rest of their lives. Their LDL should be as close to 70. Beta blockers, RAS inhibitors, and dual antiplatelets. Using multiple arterial grafts, whether be it bilateral internal mammary artery or radial arteries, is without a cause the best thing to do for the patients. STS is already discussing whether to make multi-arterial grafting a quality indicator over just the LEMA, which is currently tracked. In our group, any patient with an HbA1c less than 7, less than 70 years will be considered for BEMA. If HbA1c is higher, we'll consider a radial along with LEMA. And finally, if patients coming in for revascularization have concomitant AFib, we should not let another morbidity reducing opportunity go by. These patients should get MAZE procedures and their appendages excluded to reduce perioperative stroke risk and mortality benefits. And finally, working closely with our to get these patients extubated. 80% of our patients get extubated on table after a sternotomy approach CABG procedure, which leads to a substantial reduction in ICU delirium, ICU stay, and reduction in length of stay. Taken together, these 6 things really enhance the recovery and the experience of patients undergoing CABG under us. Finally, I would like to end by putting out a clarion call that surgeons and cardiologists should collaborate and work together in a heart team approach. We should consider individual patient characteristics, their lesion characteristics, diffuse nature of the disease, CTOs, possibility of incomplete revascularization, and trying to preempt and treat future culprits. We should be very open about our results, and this is available at least to the informed public attending the webinars. STS is producing surgeon-specific mortality morbidity figures. MST-CVS does that, and similarly, BMC Squared does that. And that should be taken into consideration when cases are being discussed by the team as to who should be doing because we cannot afford to give a suboptimal result. And finally, for high-risk cases, left main PCIs, complex multivessel PCIs, if that's being planned, is there a safe Impella and an ECMO backup? We owe it to our patients to get a true informed consent.
I think we lost Dr. Mandel's connection there.
So we just covered a ton of content, and I know there are a couple of questions from the audience. Shinichi, there's a question here about patients with severely reduced EF in terms of like how long would you wait to optimize them before proceeding with surgery? Maybe you could answer that question. And then I also know, Shinichi, perhaps you could mention some of the sort of interesting techniques that you're using for patients with completely occluded vessels that have stents. That might be interesting for the audience to hear about too.
Yeah, I agree. Shinichi, one of the sort of responses to the Syntax trial, at least from interventionalists, is that these were first generation drug-eluting stents. There wasn't a lot of contemporary technique use in terms of IVUS and other ways to optimize PCI. But what are some of the things that have developed kind of over that time interval from the CABG perspective and from the surgical perspective to optimize outcomes?
Yeah. Okay. So let me start answering the first question from Nadia. How long are we going to wait for someone with a reduced EF? So at least my approach or our group's approach, we try to maximally optimize medically as long as possible, as long as the patient can tolerate without revascularization, which is a little bit a vague answer, but we try to wait as long as possible. That's what we do. So, it can be just, 3-4 days. It can be sometimes a couple of months, depending on how these people respond. And then, we see that the better outcomes after surgical revascularization. So, and what was the second question, Nadia? The in-stent restenosis. Yeah.
So I mean, specifically, I know like Brett is a CTO operator, but you and probably that's something that a little bit more of us in the audience are familiar with, but you have some interesting surgical techniques as well for dealing with CTOs, particularly with patients who have completely occluded stents that are in the area that you would be putting a bypass graft down. So maybe you could just let the audience know about that too.
Yeah. So I see these people, these patients are typically seen by maybe 3 or 4 interventional cardiologists, 1 to 2 surgeons, and then they all said that there's nothing they can do. Then sometimes they, just they get my name and they come to see me. So, and then what I normally do is that my background, my original training was in Japan. In Japan, interventional cardiologists are much more aggressive in terms of performing PCI. By the time they come to see surgeons, and many patients already have a full metal jacket. So I have seen many patients with multiple stents that or being explanted at the time of a bypass, and that's my background. So basically, what I normally do is I try to explant the stents, not entirely. I intentionally leave just maybe 20 or 30% of a proximal, segment left behind, so that the bypass graft can avoid any competitive flow. And then as I remove the stent, I can see multiple septal branches or sometimes big diagonal branches just opened up. And then when I give a retrograde cardioplegia solution, I can see a lot of blood flow just welling up, which means if I give a good revascularization, these septal branches diagonal all revascularized. So, and then, I mean, that's what I do. And then I oftentimes just use, only internal mammary artery. I had to unroof almost the entire stent segment, but I just do like a 3 or 4 centimeter segment anastomosis, and then that's what I do. But yeah. And what was the last question that Brett was?
I think the question was about the fact that PCI techniques have improved over time as we started using more intracoronary imaging. And, you know, do we think PCI may be getting a little bit closer to bypass in terms of the outcomes?
Yeah. I think that on the surgical side, I think about 15, 20 years ago, much more surgeons were performing off-pump CABGs, but now many people are leaning towards on-pump CABG. And that's the one, I think, a difference compared with the previous. And then because of pump CABG tend to be, you know, like less targets, you know, tend to have less, you know, incomplete revascularization. And then, you know, we learned that you know, actually on-pump CABGs are somewhat better outcomes. And some new thing is that I think now, you know, more and more surgeons are utilizing, you know, minimally invasive approach such as, you know, thoracoscopic, you know, off-pump CABGs for single vessel lesion, just a Lima LAD or just a 2-vessel lesion, or using robot, and the hybrid approach for, you know, triple vessel disease. So just to do the Lima LAD through a small incision, the rest are PCI approach. This is something new that I think just getting more popularity. I think particularly last 5 years.
There's a couple of questions in the Q&A box as well. Brett, Nadia, if you'd like to entertain.
Yeah, so the
ultimate trial.
Yeah, the question from Andreas is, do you think extrapolating the ultimate trial, and if we use IVUS for optimal PCI, that the rate of unintended revascular MI will go down in the PCI group in left main in multivessel disease? I think that that's a really interesting question. There's not really been a large head-to-head comparison of surgical versus percutaneous revascularization using what we would consider to be modern techniques, at least from the PCI standpoint. I don't think that it would close the gap in mortality for patients with diabetes, for example, with proximal LAD lesions, just because of, you know, the field effect that that Kaushik had mentioned. But I do think that, and we've seen in some of these smaller trials, that the rate of patients returning for revasc because of suboptimal stenting or instant restenosis is ameliorated, I think, by both imaging, deferring lesions that don't need to be treated, as I think Aziz is going to be talking about, and optimizing stents using imaging. So
there's another question, but maybe I think Aziz is going to cover part of it. So, so for the sake of time, do you want to share your screen, Aziz?
Okay, my turn, I guess. So thank you, everyone, for sticking with us. I'm Aziz Al-Khatib, and I'll be talking today about some of the clinical implications of complete versus incomplete revascularization as it pertains to multivessel disease patients. And so I will start with a simple, quick case presentation of a 62-year-old woman who presents essentially with new onset of heart failure. She is a diabetic. You can see from her physical exam that she's in heart failure. Her X-ray shows bilateral effusions, and her echo shows an ejection fraction of 20 to 25%. And she is therefore referred to the cath lab. And as should be no surprise, given the topic of the day, that she's found to have multivessel coronary disease. Left main is relatively preserved. She has high degree stenosis of the mid and distal circumflex. The proximal LAD is diffusely diseased, and she has a dominant right coronary artery that has severe disease in the mid portion. And so this is, in a nutshell, the heart team approach. What factors do you consider when deciding on a revascularization strategy? So certainly the complexity of disease. This is where your syntax score comes in. Patient comorbidities. This is where the STS score comes in for surgeons, LV function, how low is too low. Of course, patient preference, and then what I'll be focusing on today is the feasibility of achieving complete revascularization. Multiple trials comparing CABG and PCI generally favor CABG, particularly in high syntax score complex coronary disease. And one of the theories behind that is that CABG is more likely to achieve complete revascularization. So naturally, the question becomes, well, what if you can achieve complete revasc with PCI, how do the outcomes compare? And we'll get into that. But first, what are the predictors of failure to achieve complete revascularization? There are clinical predictors, including advanced age, minority race, impaired LV functions, and comorbidities. And then there are lesion-specific predictors. Number one, by and large, is the presence of a chronic total occlusion. I'll talk a little more about later, but that poses a particular challenge, especially for interventionalists. But bifurcation disease and small or diffuse vessel disease. So this slide here looks at the proportion of patients achieving incomplete revascularization, noted here on the y-axis and stratified by syntax score. And what you see is that there's a trend to higher incomplete revascularization with more complex disease. This is rather intuitive, but note that the trend holds true both for CABG and for PCI, with a slight edge in favor of CABG. And so to answer this question, or to explore this question of does CR with PCI achieve similar outcomes as it does with CABG, there was a pooled analysis of these major CABG versus PCI trials where over 3,000 patients were analyzed and divided into the following subcategories: PCI, CABG, and those who achieved complete revascularization versus those who did not. And I'll mention that revascularization was guided by an anatomic definition. In other words, physiologic data was not incorporated here. Here are the outcomes for the PCI groups. On the left panel, all-cause mortality. On the right, the combined endpoint of death, MI, or stroke. And what you see is that patients who achieved complete revascularization with PCI did better. That was not statistically significant for death, but was for the combined endpoint. Looking now at the CABG cohorts, interestingly, the ability to achieve complete revascularization did not appear to impact the outcomes for CABG patients as it did with PCI. So, the lines essentially overlap. And this undoubtedly is due to the fact that the vast majority of these patients received a lima. So it sort of speaks to the power of the lima, so to speak. And then when you combine all cohorts together, again, this is a retrospective analysis, but it suggests at least that achieving complete revascularization with PCI may provide outcomes similar to those of CABG. Note, however, that the patients who underwent PCI and did not achieve complete revascularization, the PCI IR group fared the worst. And so just a little bit about the impact of chronic occlusions. We all know this poses a challenge. This is a post hoc analysis of the syntax trial. And the presence of a CTO automatically increases your syntax score. And so that makes it less likely to achieve complete revascularization. And that's true of both PCI and CABG, but much more so for PCI. And in fact, one of the strongest predictors of incomplete revascularization was the presence of a chronic total occlusion. So this figure shows the MACE rates at 4 years in patients who had chronic total occlusions, those who achieved complete revascularization versus those who did not. And I will mention that of these patients, only 49% had successful CTO interventions. Switching gears a little bit, what about functional significance? So we know that PCI of non-physiologically significant coronary lesions wouldn't really provide benefit. And if you believe the data from DEFER, could potentially place the patient at potential risk. In the FAME trial, over a third of patients with angiographic 3-vessel disease were found to have only 1-vessel disease when all the stenoses were measured with FFR. And so the question is, should CR be guided by physiology and anatomy rather than anatomy alone? In other words, this concept of the functional syntax score. And this is sort of depicted here, this concept of functionally complete revascularization. So you have a patient here with multi-vessel disease, multiple lesions. And so all lesions are scored using FFR. The FFR positive lesions are fixed and thereby achieving functionally complete revascularization. The residual coronary disease, the FFR negative lesions, is your residual syntax score. Again, after all FFR positive lesions are fixed. And so what is the outcome there? This is a FAME analysis and that looked at 1-year MACE events. And what you see is that in blue, for patients who had MACE at 1 year, they had higher syntax scores and functional syntax score. And again, functional syntax score uses FFR data. So you take your syntax score and you subtract the FFR negative lesions from that and only score the FFR positive lesions. And so looking at the data for the residual syntax score, you can see that there were no difference in MACE events. And again, residual syntax score is what's left over after all FFR positive lesions are fixed. So it suggests the safety of deferring FFR negative lesions in patients with multi-vessel disease after, again, FFR positive lesions are accounted for. And so sort of some final thoughts. I think the ability to achieve CR should enter into the decision-making algorithm, the heart team approach when faced with these patients. You know, I think if PCI can achieve complete revascularization, then perhaps outcomes may be as good as CABG. That's debatable, certainly. Keep in mind, however, it's not easy to achieve complete revascularization. These trials generally at best were 60%. That's true for both CABG and PCI, again, with an edge to CABG. The functional CR, you know, using FFR guidance is probably a better goal to strive for than simply angiographic complete revascularization. And that's simply because the after functional revascularization is achieved, the insignificant lesions don't appear to increase the risk for MACE. And so I generally use and urge the use of FFR when tackling multi-vessel disease patients. So I guess I would ask the panel, how do you guys use FFR or physiologic information when you approach your multi-vessel disease patients?
I'm happy to jump in, and then maybe Brett and Shinichi can weigh in as well. I mean, definitely if a lesion is not causing ischemia, then, and if it's in a stable coronary disease patient, I think I agree, you know, managing it medically is probably very reasonable. You know, of course, when it comes to if the patient's going to have a bypass graft, you probably wouldn't want to put a graft on a vessel that doesn't have, you know, a functional significance because of the risk of the bypass graft not remaining open, too much competitive flow. You know, I think also, you know, when it comes to CTOs, that's always a little bit tricky because, you know, you could have potentially some abnormal functional significance in the region of the CTO. So you go ahead and you fix that. And then the question becomes what to do with the CTO. And maybe Brett can weigh in on that part, just because I kind of tend to go based on patient symptoms a lot of times, unless it's a patient who's had a STEMI, because again, you know, with complete revasc, actually CTO interventions were included in that revascularization if the operator was familiar with CTO revascularization. So I don't know, what do you think, Brett and Shinichi?
I think definitely we use a lot of FFR now to determine when we can defer lesions and to kind of almost restage a patient. Patient who we think might have 3-vessel disease actually ends up having 2-vessel disease. One of the questions that I think about a lot is if we have a positive or what we consider to be an FFR significant result, and we think about the implications of that within the confines of the FAME data, indicating that, by treating these lesions, we can reduce, the need for further urgent revascularization. How should the FFR results guide a surgeon placing a graft to that vessel? And I think, Shinichi, you can jump in. I think if we tell you that it's FFR positive, you're typically going to attach a graft to it. I'm not sure, what the long-term implications will be for that graft, but that's been our practice, I think.
Yeah, I think FFR, has become really useful, measure, whether we should graft or not, and then, on the surgical side as well. And then I just want to mention something, then we almost always completely revascularize for CABG. And then I think one of the, biggest advantages of CABG is just the feasibility of a complete revascularization is really, really high. And that's something I'd like to emphasize, compared with the PCI. And then, CTO, I mean, it's not a big deal. We can just almost always completely revascularize. So.
Yeah, absolutely. I think it's really important, I think, for the interventional operator, the interventional cardiologist, to be honest. If there's a CTO that looks like it's, potentially of low complexity, a low JCTO score, something that is, going to be very high percentage with a lower potential complications to the patient, then that can be part of the discussion. But if it is truly something that's going to be challenging, maybe a lower success rate, or something that's going to require, something more dramatic like a retrograde approach, which, should always be in the conversation for the armamentarium, we have to be honest about that. And, that is definitely something that would tilt the balance toward coronary bypass for sure.
Well, I know we don't have very much time. Shadi, were there other points you wanted to make sure we covered, or other questions from the audience that you wanted to entertain before we wrap it up?
Just now, just clarify, I think, to Brett and to Dr. Al-Khatib point is we're doing FFR for the questionable angiographic lesion, not for the severe lesion, that the one I showed, for example, on the case earlier today. If it is severe enough, I mean, you are done, you have your answer. If it is 90%, 99%, you don't need to FFR that, obviously. It's physiologically significant. But if it is in the 50, 60%, you're questioning. Again, I mean, in the setting of, I just want to make a comment about the COVID now. Maybe it's good practice just to, if you want to finish a STEMI and then you see a lesion in circ and you drop a pressure wire and see what is this lesion significant or not. So you don't need to bring the patient back to the lab and subject him and the staff and the COVID testing and all that, the hassle now. Which has helped you a lot of the time planning your next step during COVID pandemic. But this is something you can do easily during the procedure, unless there is a contrast limit, the patient is stable, he's on Impella or balloon pump, or he's hypotensive, or any pressors. Well, I think we are right at the top of the hour. I just would like to thank everybody for your time and for preparing the slides. Really, it's been a great program, and I would like to give a special thank you to Alice Pitts, who, without her, I mean, this program wouldn't exist. She put all this together, and she kind of hustled a lot to get the slides and to put the reminder and send the invitation. And thank you so much for all that you do, and Dr. Michael Gallagher for taking the lead on this program, and from the educational standpoint, it's the educational arm of the chapter. Thank you so much for your commitment, and Dr. David Woons for your leadership and believing in the idea of virtual learning right now, especially in the COVID pandemic. Please remember, all these webinars will be recorded, and we'll be editing them and put them on the Michigan Chapter ACC YouTube channel. You can see them at any time; they are on demand, yeah, we're gonna obviously record. This is a recorded session as well. Will be also edited and posted there on monthly basis. Dr. Gallagher.
Well, great. Thanks, Chadi. And just also a quick thank you to all the fantastic faculty. This is really a great collaboration between the Detroit Medical Center and Michigan Medicine on a really important topic. We really had superb content and presentations, and I appreciate you all for participating. And really, we've enjoyed robust attendance for each of these sessions thus far. In January and February, we've had great attendance. So please encourage your fellows and your faculty at each of your institutions to get involved in the second Wednesday at 6. As Chadi said, the next session will be March 10th. Henry Ford Hospital will present emerging strategies on structural heart disease therapy. So our goal is really to have as broad input across the state as possible. So if you'd like to get involved, please let us know. And finally, I would also like to once again thank Zoll for the really generous support of this evening's webinar. And you always need to end with thanking Alice Betts and David Wone. So thank you everybody for joining, and have a great night.